Tachycardia. Tachycardia describes any heart rate above 100 beats per minute. Pathophysiology. Sinus tachycardia is usually a normal physiological response. For example, exercise, pain, fever, anxiety, pregnancy, anemia, and thyrotoxicosis. Supraventricular tachycardia starts proximal to the bundle of His and is most often caused by re-entry circuits. Atrioventricular nodal reentrant tachycardia, atrioventricular reentrant tachycardia, for example Wolff-Parkinson-White, atrial tachycardia, flutter, or fibrillation. Ventricular tachycardia starts distal to the bundle of His and may arise from scar tissue, post-MI, cardiomyopathy, electrolyte disturbance, or prolonged QT. Non-sustained VT is greater than or equal to 3 consecutive ventricular beats over 100 beats per minute lasting less than 30 seconds. Sustained ventricular tachycardia lasts greater than or equal to 30 seconds or requires intervention. Torsade de Pointes is polymorphic VT with twisting QRS complexes in prolonged QT states. Re-entry abnormal automaticity or triggered activity can all generate rapid ectopic impulses that override the sinoatrial node. Symptoms: palpitations or racing heart, lightheadedness or pre-syncope, dyspnea or chest discomfort, and true syncope, usually with VT. Signs: pulse over 100 beats per minute, regular or irregular, hypotension, diaphoresis, or pulmonary edema if hemodynamically unstable. Investigations: 12-lead ECG. This can confirm rate over 100 beats per minute, classify if it's a narrow QRS less than or equal to 120 milliseconds versus a wide QRS over 120 milliseconds. Look for P-wave relaxation, regularity, delta waves, or QT prolongation. Continuous monitoring, telemetry, 24-hour Holter, events recorder, or implantable loop recorder for intermittent episodes. Bloods: full blood count, UNEs, magnesium, calcium, thyroid profile, and troponin if ischemia is suspected. Imaging: echocardiography for structural disease, cardiac MRI or CT if indicated. Complications: hemodynamic collapse, cardiogenic shock, degeneration into ventricular fibrillation, sudden cardiac death, thromboembolism, particularly with atrial fibrillation, and recurrent syncope and trauma. Management: initial approach: perform an A to E assessment, give oxygen if hypoxic, establish IV access, and attach monitoring or defibrillation pads. Identify instability: systolic blood pressure less than 90, syncope, chest pain, or pulmonary edema. Any unstable tachycardia, immediate synchronized DC cardioversion of up to 3 shocks. Regular narrow complex tachycardia, likely supraventricular tachycardia if stable. Attempt vagal maneuvers, Valsalva, and carotid sinus massage. If ineffective, give IV adenosine 6 mg, then 12 mg, then 18 mg in rapid boluses if needed. Consider calcium channel blocker, verapamil, or beta blocker if adenosine is contraindicated. Irregular narrow complex tachycardia, atrial fibrillation or flutter. Control the rate with IV beta blocker or diltiazem Consider rhythm control, DC shock, or amiodarone if onset is less than 48 hours or hemodynamic compromise. Assess stroke risk, CHADS VASC score once stable. Wide complex tachycardia. Treat as VT until proven otherwise. Give IV amiodarone, 300 mg over 20 to 60 minutes, then infusion. Or consider procainamide/lidocaine as per the local protocol. Post-episode care. Correct electrolytes, review QT prolonging drugs, start beta blocker for structural VT, and refer to electrophysiology plus or minus ICD implantation as indicated. That was the full video, and there's hundreds more like it waiting for you at finalmed.co.uk. Get over 9,000 UKMLA exam questions, hundreds of animated videos, and our trusted textbook all in one platform designed to make your revision faster, clearer, and exam focused. Start your free 7-day trial today